All right. Probably had some of this when you were talking about in A&P, when you're talking about the cardiovascular system. But let me start off with the cardiac output. The cardiac output is the volume of blood that is pumped around and round and round in a minute's period of time. And it is the product of the stroke volume times the heart rate, where stroke volume is the volume of blood that is ejected from the ventricles with each ventricular with each ventricular contraction. It's roughly somewhere on the order of 60 to 130 milliliters per beat. Normal heart rate somewhere between 60 and 100. If you kind of just do middle points of that, 70 times 70, roughly 5,000 milliliters per minute, or 5 liters per minute. And that cardiac output directly influences what the blood pressure can ultimately be. You can contrast this with this formula. Because they're kind of looking at the same kinds of things. How much per event, how many events per minute? 4 to 8 liters, yeah. This here. One of the many normal values and formulas that you'll end up having. Our blood volume is normally about 5 liters, which ironically is what 5 liters per minute happens to be the normal cardiac output. So we basically recycle the blood through the body one time every minute. Vast majority of blood is in the systemic circulation, and of that, again, the capacitance vessels, the veins have 60% of that. 15% is found in the heart, 10% is found in the pulmonary circulation. It has a very small capacity, usual volume being under 100 milliliters of blood inside your pulmonary circuitry. Blood flow is gravity dependent in the sense that in the upright lung, you sitting here, none of you are sleeping yet, but if you're sitting up, the vast majority of your blood flow would end up going to your bases, to the lung bases. If you're lying flat, it would obviously go to the posterior portions of your lung. This is kind of a graphical showing where the majority of the blood flow would go in relationship to turning a person on its side, having them in B, they're just lying supine, and C, they're lying on one side or the other. Ventilation is also gravity dependent. There's a little bit of difference as far as what goes on here. For one, at rest, at the end of a normal exhalation at FRC, functional residual capacity, the alveoli and the bases are smaller in size than the alveoli in the apices. So that FRC is not evenly distributed throughout the lung. The apices actually have a little bit larger alveoli. So when you take a breath in, majority of the volume goes to the bases because it can't go as much to the apices because they're already full. The reason why that occurs has to do with the difference in transpulmonary pressure. We don't want to go there. So for right now, let's just take my word on it. They're bigger in the apices, smaller in the bases, so when they fill, they're predominantly going to be filling into the bases. So both ventilation and perfusion are gravity dependent. Yeah. And for right now, because you'll never remember this, but we'll come back and visit this next fall at this time. Sometime I'm going over with the second years. There are different areas of the lung that have been theorized, zone 1, zone 2, and zone 3. We don't need to know it for now. But that's basically just showing that there's a difference in distribution of ventilation and perfusion. Okay. Here's the important part that I want to get to, why I'm talking about this. So we have a unilateral lung disease. Say I have a massive pneumonia, fractured ribs, pulmonary contusion on one side, only on the left. Deceleration injury, unseated, unbelted driver, hits the steering wheel with his left chest. Develops broken ribs. I don't know if we talked about this before, but the lung is like any other tissue. If you hit it hard enough, you'll bruise it. And in a deceleration injury, your lung is just suspended inside the thorax, and if it hits the front of the, or hits the steering wheel, if the ribs hit the steering wheel, the lung's going to hit the ribs, and you'll get a bruise, pulmonary contusion. But it's only on one side. So when we ventilate, preferentially, the gas isn't going to go to that side. So what we want to do is position the patient with the bad lung up, so lying him on his right side, and kind of forcing perfusion and ventilation to that dependent area. So they're trying to match the two of them. Because if we were to lie him on the opposite side, we would end up having a situation where ventilation isn't going to that left lung, but perfusion is. Does that make sense? Kind of, sort of. Good to ground is the thing to remember. Bad lung up, good lung down. We'll match ventilation and perfusion together. I always tell the story of, what's his name? Norman. Norman was a C2 fracture, involved in an automobile accident, snapped his neck, paralyzed from the neck down, basically. Most he could do is blink and do one of these kind of things. No function in his arms, legs, nothing else. And he was paralyzed and need to be mechanically ventilated also. So he was on a bed. They were trying to keep him from developing bed sores, trying to keep him mobile. So what he was on was a bed that would rotate one way, come back to middle, rotate the other way. So it was doing a lateral roll. And it would do this over a minute's period of time. So very gradually you would see this change happening. He had a unilateral pneumonia, pretty bad on one side. I think it was the left, actually. And this is in the early days of pulse oximetry, but we were monitoring his oxygen levels continuously. And as he would turn, so the good lung was up, his oxygen levels would fall, and as they rolled the other way, his oxygen levels would come back up again. It was interesting to see this theory held out as being reality. By the way, one other option that we have for unilateral lung disease is we can actually intubate with a special tube that will allow us to ventilate each lung independently. So instead of having one ventilator room, you have two. Now we're getting cool, because that's a real challenge to manage. Okay. Enough of this nonsense. We said cardiac output, stroke volume times heart rate. Well, heart rate's pretty easy to figure out. We know that we have an intrinsic pacemaker within the heart, which is the SA node, and it fires at a rate of 60 to 100. And if it doesn't work, the AV node takes over, and that doesn't work, the Purkinje fibers will fire independently at something less than 40. Stroke volume, though, is a little bit different. Stroke volume is dependent upon three different factors. Something called the preload, something called the afterload, and something called contractility. Can I make a rash assumption that those words mean nothing to you? That you didn't cover them in A&P? That's a safe bet? You talked about them? Wow, cool. No. All right. So preload, afterload, and contractility. Well, let's start with preload. Classically defined, it's the degree that the myocardial fiber is stretched prior to contraction. So at the end of diastole, just prior to that ventricle contracting, how much stretch is on that muscle? We know that as we stretch a muscle, it contracts. That's basically the mechanism by which contraction happens. If I stretch it more, I get a bigger contraction to a point. Think of a rubber band. If I pull a rubber band this far, it's going to go a certain distance. If I pull a little bit farther, it's going to go further. If I pull too far, it snaps, right? So there's a limit to how much you can end up getting out of this. But what determines that amount of stretch is how much volume is inside that chamber. Let me say that again. What determines how much stretch you get, how much contraction you get, is how much blood is in that ventricle just prior to contraction. We call that preload. So if there was a way by which we could determine how much volume was in that chamber just prior to contraction, I can get an idea, do I need a little bit more in there to stretch that fiber more? Do I got too much in there? Should I take some off? Okay. But preload was one of the factors that's going to determine how much blood is ejected. If I cut off Sherry's arm and she's bleeding all over the room, her preload will go down because there's not as much circulating volume. Okay. Before I get to that second and third bullet point, let me go ahead and just kind of tell you a story. Once upon a... No, it's not one of those stories. Here's my heart. Four chambers, right? If I'm really interested in systolic blood pressure, or systemic blood pressure, let's say that again. Well, what we measure in our arm. I know that part of what influences this is cardiac output. And what influences cardiac output is heart rate and stroke volume. So really what we're interested in is left ventricular stroke volume, because that's what's going to determine blood pressure. Well, one of the things that influences stroke volume is this concept of preload. Specifically, preload of the left ventricle. How much blood is here just prior to ventricular contraction? What is the volume in the left ventricle at end diastole? Just prior to the contraction, mitral valve opens up, dumps all the blood from the right atrium into the right ventricle. Right ventricle is getting bigger and bigger and bigger as it fills. Now at end diastole, it's got a certain amount of volume in there, a certain amount of stretch ready to be pumped out. Agreed? Yeah, you don't care about it. I'll watch this again on Panopto later on, Rick. Problem is I can't measure that directly. How do I get into the left ventricle? On the right side, what the hell did he just write? Right ventricular end diastolic volume. How much volume is in the right ventricle just prior to contraction? If I have a volume of blood in a closed chamber that volume of blood is going to exert a pressure, isn't it? Or if you don't believe me, yeah, it's going to exert a pressure. So I can actually, by measuring the right ventricular end diastolic pressure, have an idea of how much volume is there. There's a relationship between those two. Put more volume in there, pressure within that chamber is going to go up. Take volume out, pressure is going to go down. Well, on the right, so at end diastole, just prior to that ventricle contracting, the pressure here is equal to the pressure here in the right atria. The valve is open. All the filling has occurred between the two. There's no more movement of fluid. There's no difference in pressure. Can't move. The flow can't occur if there's no difference in pressure. So at some point, right ventricular end diastolic pressure is the same thing as saying right atrial pressure. Oh. And we have the ability to float a catheter into the right atrium. We would call this a central venous pressure, or CVP. The CVP is a measurement, a pressure measurement, that's taken inside the right atrium, or thereabouts, and allows us to evaluate how much volume is in the right ventricle just prior to contraction. When I cut off Sherry's arm, she lost a lot of blood, and in the process, her CVP fell. CVP falls, right ventricular output falls. Okay? So for years, surgeons would use central venous pressure to evaluate, do I have enough gas in the tank? Do I have enough volume in the person, or do I need to give them some fluids, some blood, something to get it back up again? Okay? In diastole, the pressure that's in the right ventricle is the same thing as what's in the right atrium, and I can measure that directly and have an index of how well that ventricle is being stretched. What is the preload of the right ventricle? And that preload is indicated by the CVP. On the right.
Can you repeat that?
I doubt it, but go ahead.
In diastole, the pressure in the right atrium is equal to the pressure in the right ventricle.
You just said it.
Okay.
And why is that true? Because at the end diastole, the tricuspid valve is open, and all the volume that was going to be moving from the right atrium to the right ventricle has already done it. And because there's no more flow, that means the pressures must be equal. The volume is not simply because the size of the two structures are different, but that amount of volume that is there is tied to that pressure. There's a direct relationship. Increase the volume, increase the pressure. So that part is definitely true. The quantifiable volume isn't. Okay. So we're using pressure as a surrogate, as a good guess what that volume is. And for the most part, it's pretty true. Okay. Right ventricular preload, CVP. Problem is, I don't care about the right ventricle. I want to know the left ventricle. Maybe I could just drill a hole into the right ventricle or into the left ventricle and measure the... No, that wouldn't work. So these two docs, Dr. Swan and Dr. Gans, they were two cardiologists out of California. And I forget who it was, if it was Swan or it was Gans. But they were sitting, one of them was sitting in Santa Monica Bay watching the sailboats go by. Nice summer day. Kind of like we're not going to have. And he noticed that when the wind came, it caught the sails and pushed the boat along. Big duh, right? Well, the problem they were having is they were attempting to catheterize the pulmonary artery. But every time they floated a catheter through, where's my pen here? Every time they tried to float a catheter through the tricuspid valve, it got hung up inside the right ventricle because it had no path to follow. But wait a minute. What about if we put a sail on the end of the catheter? Something to give it some guidance, to help it follow the flow of blood. Voila. The pulmonary artery catheter was created. It's still to this day called a Swan-Ganz catheter, even though it's generic by now. And by the way, it's Swan-Ganz, not Swans-Ganz. It's like, poor Dr. Swan gets his name maligned. But they actually had the ability. Let me go back and draw a couple other things here. Here's my pulmonary artery. And when they went ahead and floated that catheter, they would go ahead and float it in through the right atrium, through the tricuspid valve, get into the right ventricle, inflate the balloon, and it would just follow right through the pulmonic valve and into the pulmonary artery. Magic. Why did they want to do that? Well, what's after the pulmonary artery? As far as vessels are concerned. Pulmonary arterial, pulmonary capillary, pulmonary venule, pulmonary vein. Where does it end up then? What's after the pulmonary vein? Where do the pulmonary veins dump to? What part of the heart? Left atrium. Oh, okay. Left atrium. Imagine that. And so, in theory, if I could measure the left atrial pressure at end diastole, that's equal to the left ventricular end diastolic pressure, which is going to give us an indication of what the left ventricular end diastolic volume was, which is what we want to know. How much blood's in the ventricle? What's the preload on the left? Think back when you were a kid. Now, maybe you still do this. I don't know. It's kind of an odd thing, but you got a glass of soda, right? You got a straw in there. What happens if you take the straw, put your finger over the end, and pull it out of the pop? It stays there, doesn't it? It doesn't move. Why doesn't it move? It doesn't move because the pressure is equal throughout. There's no change in pressure. So if I know the pressure at the top, it's exactly the same as the pressure at the bottom. Agreed? No pressure difference, no flow. So what they did with this pulmonary artery catheter is they floated the catheter along with the balloon up until it got stuck, until it wedged into one of the small pulmonary arterioles. And then they measured the pressure that was at the tip of that catheter. Just like the straw, the pressure at the tip of that catheter was exactly the same as the pressure in the left atrial. Magically, I now had the ability to assess left atrial pressure, and by extension, left ventricular end diastolic pressure, or how much volume was in the left ventricle prior to contraction. And it's been given the name, where am I here? Pulmonary. It's raining in Columbiaville, just so you guys know. And Carroll. Pulmonary capillary wedge pressure, PCWP. One of the measurements that it's able to measure. And that's the preload on the left. Preload on the right, CVP. Preload on the left, pulmonary capillary wedge pressure. It's a magical story, and it made some people a whole lot of money.
Is that catheter got like a camera on it or something? How do they sense where it's going? They're just doing it
no. Funny you should ask that, because that's the next thing I'm gonna talk about. Let me just go back here and make sure I covered both those points I wanted to. So on the right side, that right ventricular end diastolic volume is reflected by the right ventricular end diastolic pressure, or CVP. On the left side, it's indicated by the wedge pressure. So this pulmonary artery catheter, created by Swan and Gans, allows us to see what's going on the left side by doing a right-sided measurement. And for the most part, it's pretty accurate. There are some caveats to that, but I'm putting a catheter into the right side of the heart. We talked about being wedged, measurement of the pulmonary wedge pressure, blah, blah, blah. This is what the catheter actually looks like. And there's a balloon on the very tip that I inflate. There's a pressure point that I can measure the pressure at. And it also has the ability to measure cardiac output directly by using a process called a thermodilution technology. We'll leave it at that. What happens when the catheter is being advanced? Well, I'm going into the superior vena cava, going into the right atrium. It now passes through the tricuspid valve. Now, when that tricuspid valve closes, there is a pressure difference between the two, and I can actually see that on the monitor, on the oscilloscope. Then, when I cross from the pulmonary, cross from the right ventricle into the pulmonary artery, there's another change in pressure between the two. And I have another slide on this later on, but let me just kind of white is not the best color. So here I have my CVP pressure. Cross the tricuspid valve, cross the pulmonic valve, and you actually have a change in the waveform. And they can tell exactly where they're at by watching this. But again, and just so I'm clear, that balloon that was inflated and is wedged, we can't leave it like that forever, because that would mean that all the blood flow distal to that wouldn't be getting any blood flow. And if you remember, the alveoli get their blood supply from the pulmonary artery. There's no systemic artery giving them oxygen and removing waste products. So we have to deflate that balloon. When we deflate the balloon, we're measuring pulmonary artery pressure. Right? Systolic, diastolic in the pulmonary system. Very low pressure system. Somewhere on the order of 25/8. Inflate the balloon, Catheter floats forward, gets wedged, measure my wedge pressure. Deflate the balloon, it goes back to measuring the pulmonary artery. So it's kind of got the best of both worlds. And this is just, again, talking about preload as a concept. As you increase the preload, you increase the stroke volume, increase the stroke volume, increase the cardiac output, increase the cardiac output, increase the blood pressure. All goes one after the other. Let me say that again because I don't think I caught it. Preload's low. Sherry's got her arm sawed off, right? I give her some, I put a catheter in to measure her pressure. Her preload is low because she's lost volume. Preload is low, cardiac stroke volume is low. Stroke volume is low, cardiac output's low. Cardiac output's low, blood pressure's low. Because they all build on each other. But the starting point is that preload. That starting point is how much fuel is in the tank. So what do I do? Well, first of all, I sew her arm back on, stop the bleeding. And the next thing that I do is I replenish that volume. I give her some IV fluids. I give her some blood. How much? I don't know. So her blood pressure looks better. Let's measure the CVP. Let's measure the wedge pressure. I know exactly how much I need to put in until I get that value back to where a normal value is. All right. Yes?
You had said when the balloon was deflated,